Welcome to our Spotlight on Health Policy, brought to you by your Institute for Health Policy and Leadership. Tell by the turnout today that all of us sense the importance of this topic of homelessness in relationship to healthcare. We have three individuals who are going to share of their expertise. So our first guest is Dr. Anthony Ruffin.
Like the gentleman said, I've been doing this work for 19 years. A little bit backstory about myself. My father was chronically homeless for 25 years. My stepmom was homeless since 1968. Chronic mental health issues. She cut herself all the time. She panhandled on the streets. And she died on Skid Row probably about 2 years ago. My biological father currently is still living on Skid Row. He's 71 years old. I'm his only family, his only hope. My aunties that I never even knew, they don't talk to him. They don't do anything for him. So it's primarily up to me to take care of my father. And I do this work with a passion. I really do. The gentleman there, I had to cry. He passed away probably about 6 months ago from cancer. And we had to fly his body back to Texas to his family. So that's the kind of work that I do. Most of the time, the clients that I receive them from paramedics, LAPD, other social service providers, and community stakeholders in the community. And they usually target people that have been in their communities chronically homeless 15 years, 20 years. Have you ever been in LA and you drove around LA and you worked in LA, you've seen it all the time. That person is always sitting on that bus stop when you go on to work, come from work, they're always there. And what I've learned about this population is that the older they get, the more they don't have anybody around them. Family members pass away, they get lost in the system, there's nobody there to care for them. And what I try to do is care for people like I would want somebody to care for my father. And I try to navigate systems, hospital systems, conservatorship systems, boarding care systems, supportive housing systems, HACLA vouchers, HACOLA vouchers, with the Section 8 vouchers, benefits advocacy, GR advocacy. I do it all for individuals because I honestly believe that I'm their voice. Because if I get turned away, they get turned away. And that's how I approach the work. It is grueling work, it is tiresome work, but it's very rewarding work. Very rewarding work. Like the gentleman said, I've worked all around LA County, and it's a lot of success stories, but more importantly, it's a lot of failures. And those are the ones that hunt me at night, to be honest with you. I believe that all social service agencies and all case managers and all outreach workers should be working in the rain. They should be working in the cold. And that's what I do. I go out late at night and I work with people because in the rain and in the cold, that's where you find your most vulnerable. And it can be for all type of sorts of things. I met people that were elderly, the spouse passed away, they lost the house, and they're out on the streets. Become instantly vulnerable on the streets, which is insane to me. I've met foster care youth that's been on the streets forever and a day that's never really even had permanent housing. I've worked with people that were severely mentally ill and were under conservatorship and got off their conservatorship, were too ill to reestablish their benefits, to find housing, and ended up back on the streets eating out of trash cans. A lot of trauma, a lot of trauma, a lot of trauma. I've been out there, and women are constantly raped on the streets, constantly abused on the streets. I have compassion for those people. I have a lot of compassion for those people. And I really don't look at it as work. I look at it as a privilege. It's a privilege for me to leave my four walls and go out there and help another individual. It's not about the pay, it's about the work for me. It's really about the work for me. What else can I say about myself? I started off in social services, like I was telling this gentleman, as a janitor. I started off as a janitor in social services. And I did that for like 6-7 months maybe. And I went to HR to ask me what did I want to be. And I told them I wanted to be a case manager. And they basically told me I was too stupid to be a case manager. And that's what lit the fire for me. That's what lit the fire for me. And I told the gentleman my biological father left when I was 6 months old, and he was in and out of my life till I was like 8 years old, and he just disappeared. He just disappeared. Never seen him again. And every Christmas, every Thanksgiving, my birthdays, I would think about him constantly. And another social worker told me where he was at. And I met my biological father, and that there just brought some peace into my heart. And I do this work because I know it's family members that are looking for their loved ones. And they want their loved ones to be safe. And what I most definitely try to do with all of the people that I work with is connect them back to their family. If it's just a phone call to say, I'm okay. If it's just a phone call to say, I'm okay. Because I know if my father would have given me a phone call and told me he was okay, I probably would have slept better during Thanksgiving, Christmas, and my birthday, and everything else. So, that's a little bit about my background. Like the gentleman said, I've worked for different agencies, social service agencies, because I believe in a philosophy that in the health field, social service field, we're all here to help people. And if some people's policies don't line up with that, I leave. I just leave. I don't stick around. I don't stick around at all. Problems navigating systems. We want to talk about that. Like a person get into the hospital on a 5150 hold. You put them on a hold, and they're discharged the next day because of insurance benefits. Or the administrators don't see that this person is worthy of staying in a hospital because of the way insurance works and the hospitals work, because the hospital is overburdened with these type of individuals because they know they got to hold on to them for 6 months to 8 months until an IMD bed opens up. And that's just a big system problem. That's just a big insurance system problem. It's just a huge problem. It's a state problem, to be honest with you. I've been in emergency rooms and I've met amazing doctors. I've met amazing people that really, really care. And they'll tell me there's nothing really too much I can do. Our hands are tied. You know, and I know it's a system problem. It's bigger than me. It's bigger than us. And I think that in LA County, for instance, I know that they didn't put too much money into mental health over the last 25 years until Triple H money just came out. And the infrastructure is not there for these individuals. And these individuals are super resistant to services because they've been traumatized by our system. They've been put in hospitals, left there alone, and they've been treated bad in the hospitals. They've been treated bad by social service agencies, and they've been kicked out and they lost everything. And so they don't want anything to do with us, and they rather sit on the streets. And I try to go in and change that model for them because it's so much not about me. What I usually say is your path to housing, not mine. Whatever housing looks like for you, not for me. And we'll go on that journey. We will definitely go on that journey. And sometimes that journey is hospitalizations. Sometimes that journey is substance abuse programs. Sometimes that journey is domestic violence programs. It all varies, but it's their journey. And it's my job to just support them and be their voice. And I think that's the most beautiful thing when I house someone that's been on the street 15 or 20 years and it's just me and them in an apartment for the first time. And they look at me and cry and say, thank you. Thank you for supporting me. And I don't think I get paid enough for that. I don't think I can get paid enough for that. To house a senior that's been out there 10 years, that's been riding the bus for 35 cents a night and riding the bus back and forth through LA all night because that's the only safe place they have to live. Because their spouse passed away. It's so many stories. The first story that really got to a friend of mine named Bill. He was on the streets of Santa Monica for 15 years. And Bill, I just couldn't figure it out. I knew he got his benefits check, his retirement check, and every day I would see him, he would be broken. He'd have a pack of cigarettes and a lottery ticket. I was like, there's no way you can move into housing if you just, what are you doing with your money? And the last time I saw Bill, he had caught throat cancer. He had throat cancer. It was on a Friday, and I see him on a bus bench, and I said, I'll see you Monday. And he said, I'll see you Monday. As I rode away, he died on that bus bench 2 hours later. And the amazing part about him, after he passed away, what I found out, that he would buy himself a pack of cigarettes and a lottery ticket, and he would send that money back home to his daughter so she can go through college. And I had no idea. I had no idea. So for me, it's for me not looking at homelessness, but looking at the person. Understanding what they're going through. Understanding what they're going through. And I believe that social services should not be protecting policies and procedures, but looking at the human beings. Human beings, because they're human beings. So that's why I do the work, and I do it with a passion, and I do it 24 hours a day. Because I'm kind of nosy too. I won't lie to you. I want to see what's going on with my client at night. I need to know the whole person, not just the person I see from 9 to 5. I need to know the whole person. If I can't understand what they're going through, I can't help them. And they're not going to tell me everything. There's some things I just got to see for myself. So I make sure I see all my clients that are on the streets at night. And when we talk at night, and I look at it as it's like my office. There's no traffic, there's no people walking around. It's just me and him. And we may not even be talking about social services. We might be talking about baseball. You know? And it's just having that human contact. It's a health policy. And I think that health plays a huge role in all of this. Because all of the individuals that I've housed passed away from acute illness, medical illness that was probably preventable. Probably preventable. And that's the sad part. My friend here, he passed away. It was preventable. It was preventable. So in LA, we have this housing first model. We do the housing first model. We do all of this other stuff. But we don't talk about the health needs of these individuals. we don't talk about that too much. And I may be able to go to a psychiatrist and ask a psychiatrist what's going on with the mental illness, and they get prescribed some medication. But I don't have a doctor standing there next to me. I don't have a nurse standing there next to me to let me know why their foot is swollen up, to tell me it's heart failure. I don't have that. I don't have a nurse practitioner out there that can check somebody's blood pressure to let me know they have high blood pressure. I just don't have that. And I believe that looking at the whole person, we need to look at the health too. Because if we have health professionals out there on the ground, it would probably save the hospitals a lot of money. Because we're doing preventive care on the streets. They're doing preventive care for mental health on the streets. They should be doing preventive care on the streets for health too. And I don't think the hospitals would be overtaxed if we had health professionals out there really helping us with this work. And that's just my belief. That's just my belief. My belief. You know, it's people out there, amputees out there that are suffering. And when we try to get them appointments, it's almost impossible to get that appointment. If we had a psychiatrist, I got a psychiatrist walk with me, they can look at the amputee and be like, well, they're depressed. They give them medication. But there's nobody there to tell them what's going on with them physically. Because I believe information is key. And I'm not a doctor, and I'm not a psychiatrist. And all I can try to do is connect them to a PCP, and that appointment may be a month, 2 months away. So this person's just sitting on the streets waiting on that appointment. You know, I don't see anything humane about that at all. At all. What else can I say?
California legislature recently passed Senate Bill 1152, which prohibits hospitals from discharging homeless patients without proper planning. And so we have a question for our next speaker. What are the necessary steps at Loma Linda University Health that we can take to adjust to this new law and the challenges that we foresee here? So Mr. Paul Arias is currently the Assistant Vice President for Care Coordination for Loma Linda University Health.
Good afternoon. Thank you all for being here. It's good to see so many people here. Compassion, empathy. I think what we just heard was an angel on earth going out there helping such a vulnerable population. And to address some of the issues that came up with the Senate bill and how we would position Loma Linda to be ready to execute those rules, we did an inventory of what we already have been doing for a number of years. As we went through the bill and all of the different sections of it, we realized that we were doing about 90% of this. I think the reporting component was probably the one that was the most lacking. And so I started doing a little bit of research on some of the data that was going on in San Bernardino, California, and specifically here and around Loma Linda. And as you can see by this slide, and as was mentioned earlier, California has a substantial number of homeless that we have in and around our area. If you look at LA, 55,000. If you look at Southern California, it's an incredible number of people now. Part of that is just the location. I think if we're going to be homeless, having better weather is going to be a little bit helpful, but it still gets cold at night, it still gets rainy. It's still tough. It's tough to be on the streets. I'm a former New York City paramedic, and I can tell you that way back when on the streets, dealing with the homeless there was extremely difficult. But the population here is so much worse than anything I have ever seen before. So we started looking at some of these numbers, and in San Bernardino, there was a survey done, and this is federally mandated. They do it at the beginning of January for the first 10 days of January, so it's a kind of a snapshot in time, because the numbers kind of change back and forth as you go through what's going on. And you know, some of the things that came out of the survey is that between 2017 and 2018, there was a 13.5% increase in homelessness in San Bernardino. As you can see that we have 2,118 counted individuals. Of this, there is a substantial number of what we call unaccompanied women who are also homeless. And they make up a substantial number of these patients as well, and we saw an increase of 38% of those patients, and they're chronically homeless. Of the chronically homeless themselves, which is, according to the survey, 348 people, 48% had a chronic health condition. So about half have chronic health conditions. Of those, 46% had a physical disability, and about 4% had HIV or AIDS. If you think about the population that we serve and the homeless and the chronic illness, it goes hand in hand with what you had heard earlier. When I look specifically to our locale in Loma Linda and Redlands, in the survey, there's about 400 homeless in this area, and about 300 of those are actually unsheltered in Redlands themselves. So we have a substantial number of patients that we see here, and when I looked at what our actual numbers look like, 1.3% of our population last year was homeless. It's about 275 patients. So roughly about more than half of the total homeless population has come through these doors at one time or another. When we looked at the emergency department and how many people that come in and out through the ED, we see about 50 to 60 per month. Some months are much higher, some months are less. Weather dependent, time of the year, flu illnesses, we see these things. So that was some of the statistics that we saw, and we had to look at that, because how do we position ourselves with the personnel that we have in order to ensure that we're meeting those standards? Well, a lot of those standards was about assessment and planning. And the social work staff that I am so lucky to have under me already does such a tremendous job with our homeless population. We have had a charity fund that provides us with the ability to buy clothing, so that if a homeless needs clothing, we can provide them with. We've also partnered with community providers in order to have agreements for room and board and skilled nursing facility beds, and we'll put homeless there too to make sure they get care. We have a home health agency that we work with. It's ours, it's Loma Linda, that we have taken homeless and we've put them in hotels so that we can get them the care that they need. So it's a continuum. And we're looking how else we can partner with other people. How can we get case management involved, like what Anthony does? How do we get a caseworker? And through some of our venues, we're trying to see that we're working with our SAC clinic, which is our Federal Qualified Healthcare Center, to see how we can potentially create a homeless clinic there. Dr. Belliard does a lot of our outreach programs, our community health worker programs, is helping with us. So we're looking to see how can we impact the homeless population. And it's not because the bill mandated it. We've already been doing this. But one of the things that we did change in order to have a better view into what's going on with our patients is we created a specific charting area within our own EMR so that we can assess every single component of what that bill says, so we can have better information so that we can improve our processes to help our patients. That went live this Monday. The bill it's not enacted until July. We felt it was very important for us to start this now so that we have a better understanding of what our needs are and what the needs of the population that we're serving. So these are some of the things that we're doing to try to address what's going on. One of the other things that I have been able to do is work with what's called GIS mapping, geospatial mapping. And what you see up here on the screen is a geospatial map of our hotspots of where we have patients who have multiple admissions. Now, this one is of readmissions, but that also entails many of our chronic homeless patients and where they come from. From that, we can go down a little deeper and actually see what those hotspots are. From this map, we were also able to get the most common zip codes from where they are and tie this to census data. So we could look at the material deprivation. Because it's not just about the homeless, but it's also about those who could become homeless. What can we do to help those prevent them from getting to homeless? We have a very robust transitional care team that works on a lot of our Medicare patients, and they're very vulnerable population too. Many of them are dual eligibles. We find many of our homeless have Medi-Cal, usually through IHP or others. And so we have an IHP team that also works in the hospital to identify these patients so we can get them chronic care. So it's not just out the door and you're gone, but it's kind of wraparound services. Maps like this help us understand where those services are needed. This map has another layer which has resources in the community. So we can actually look quickly to see where are those resources. Where can we point somebody to go get a shelter? Where can we point them to go get a clinic? Where can we send them to get food? So we can actually tie the community services into what we do as well. So these are some of the things that we're doing. I'm sure as time goes by and we have better data, we'll be able to expand our services and work with other community providers. Thank you.
Our next speaker is Emilio Ramirez, the director.
I wanted to talk a little bit about the initiative that the City of Riverside is working on, and I assure you that the initiative that the City of Riverside is working on is not rocket science. It's not new. Everybody knows all the stats, and honestly, the delivery of homeless service, and not even homeless service, family living environment, children, everything, is not really about housing. It's more about social service. It's more about the effort that that Anthony and medical services and et cetera undertake. But it's also something that cannot, in my opinion, cannot effectively be reached without a global effort in the delivery of that service. So housing unit, an affordable housing unit, a supportive housing unit, one that is indicative of the way that some of us grew up in a family that supports us, that loves us, that brings forth the heart and compassion that Anthony is describing for his family, and not just his immediate family, but the family members that he makes every single day. I think it's important. But the thing that my life has been about is affordable housing development, supportive housing development. Ultimately, my entire career has been in development services, in real estate development, property development, and building farm worker housing, building permanent supportive housing, several hospitals, 6 homeless shelters, and on and on and on. I just firmly believe that affordable housing, supportive housing is needed. It has the ability to balance a community. It has the ability to eliminate poverty. It has the ability to bring forth, along with everything else, along with the service and the support that is needed, that was described by the previous 2 speakers, to bring forth that family supportive environment that it takes. I believe in a large part that poverty is not only about the size of your income, but the livability of your environment, of where you are, and the people that are around you, and the environment that is around you. Are you cold? Are you hungry? Is there someone next to you that can talk to you and love you and care for you? And if those things don't exist, then you're just more poor than the income really allows you to exhibit. So I think that we need to invest in our neighborhoods. We need to invest in our communities. We need to invest in our people and deliver a better service to ourselves, including providing a better standard of living. Housing is affordable if a family can pay for that cost of that housing and the rent and still buy food, healthcare, diapers, other essentials. Housing is not affordable when all you can afford is to pay the rent, okay? When you have to make sacrifices for the quality of your living environment, it's just not affordable. And it needs to be delivered in a way that it's not cheap housing, okay? It needs to be delivered in a way where the quality of the place that you live is still a viable place to live. It's still a viable place that you're going to receive that support service, whether it's from a case manager who is your friend or your family or from your actual family. And that, whether you live in any one of the pictures on the screen, I can't believe that can be considered housing. I mean, I guess you're living there, but it's not housing and it is not healthy. It is not a place that can provide support services. So if you have to decide to live in an environment such as squalid housing, then you're damaging your health, you're damaging your future, and for that matter, you're damaging your ability to provide a future for your children. I can tell you, like you know, and we've all learned that there is a significant diversity in our population. Not just cultural, not just ethnicity. And as an aside, I firmly believe that diversity should be celebrated. There isn't, it's all great thing to have a diversity. We should work and live together and we should celebrate that diversity. But there is a bigger difference between people of different ethnic groups than there is between rich and poor, okay? There's a bigger difference if you're poor versus you're rich versus if you're white versus you're black, okay? It just is. And when you're poor and when you have no environment and no support, you make decisions under a different lens. And sometimes decisions are made for you without you having an ability to really change it. And I believe that poverty, like Gandhi has told us, poverty is the worst form of violence, and we bring it to our friends and our family. And we know that poverty is inextricably tied to homelessness. It just is. We know this. Whether it's I was watching a documentary about 2 weeks ago, and there was a police officer that was talking to a person that was suffering from a severe mental illness, and as a result of which had started to use substance, and the police officer told her that the trauma that you're suffering, the struggle that you're in, is for rich people. You happen to be poor, so you're gonna die on the street or you're gonna get arrested, okay? And it's just one of those things that if you don't have the environment around you, if you don't have the love around you, or for that matter, the ability to pay for the service, you're going to be in a very struggling environment. A homeless person is an individual or family without a permanent housing. Someone who lives on the streets, stays in a shelter, a mission, an abandoned vehicle, a car, in a garage, a place that's not meant for a person to live. Poor people are often, and most often, frequently unable to pay for housing, food, childcare, healthcare, education. And you end up making very difficult decisions about whether today you're gonna feed your daughter or you're gonna pay the rent. Okay, that's harsh to have to make that decision. And I would imagine, you guys can correct me, that if I'm deciding whether I'm gonna feed my daughter or I'm gonna pay for rent for myself, my daughter's eating, okay? So when the person has to make a decision like that, it goes into a spiral state. So the end result ends up being a very big spiral, and it ends up being a trauma that needs to be addressed, needs to be treated. And that's a health environment that maybe was created by economics, maybe was created by a lack of support. But we do know that homelessness does fluctuate around the business cycle. This is in Riverside. So between 2008 and 2017, the unsheltered population went up and down, and it tracks almost entirely the unemployment rate that went within the same period. Okay, I mean, it's not a coincidence that that's the case. Everybody knows how much it costs to live in California, right? One minute. Okay. Everyone knows how much it costs to live in California. You guys know how much it costs to live here. I don't have to tell you, but try to imagine paying the prevailing rent. I don't know what it is in Loma Linda, but in Riverside, you have a two-person family, both earning minimum wage. They cannot afford the prevailing rent. Can't. Okay. When the cost of housing is going up, and the wages are being stagnant, and everything else continues to be needed of that family, is just difficult to do. So what's our challenge? We need to build more housing. We need to build more supportive housing. We need to build more housing that is quality and that is affordable. We need to care about where a person is surviving, where a person is living, and that housing needs to be very diverse. It has to be considered of whether the person that's going to live there is a family. Do they have a kid? Do they need to go to school? Do they need to be at church? Do they need to be near where they work? All of that has to be consistent and has to be thought of. So that they don't end up having to make a decision between having a place to live or living in a place that is maybe housing, I don't know, or not. I think that when a person is stuck between I'm going to have to move out and move into my car, okay, then did everything else that happened to them, was it created because of their homelessness, or did their homelessness happen because of their trauma? Okay, maybe both things. But I do think that there is a very big diversity in the reasons that people become homeless. You can see on the screen that the vast majority of the cause of homelessness is just simply poverty. It's unemployment, it's affordable housing, it's the cost of housing, etc. It doesn't mean that the need that the homeless population has is simply income. It also is different, and it needs supportive services. And I love this image. So this is a prescription that was given to a person that was homeless by a doctor in San Francisco. Okay, and the doctor actually prescribed a permanent supportive housing unit to the person, right? To the person that was homeless, coming in to see him on occasion, off and on, and etc. And his prescription is, you need a permanent supportive housing unit. Okay, this prescription actually was given to Kaiser Permanente, and they funded a development of permanent supportive housing units. So it is one of those things that a safe place to be, warm, shelter, brings forth help. It does. It can't abandon everything else, but it does bring forth help. And so we do need to be able to construct and build and offer more safe places to live. This is just a demonstration of the needs that the person that is already homeless. It doesn't really describe why they became homeless, but you can see the need for services and treatment, mental health, medical, case management, and just simply Okay, just to put it very, very simple, just simply the love that Anthony has just described is key. It's needed. The love that my mom gave to me when I lived in her house and allowed me to go to college is key. It has to happen. But it can't be done all at once, and we need to be cognizant of all of the needs that a person needs, from basic needs, overnights, I'm just hungry tonight, I need a place to sleep, I'm cold. And so that means building for the full spectrum of need, from a homeless shelter to a supportive unit. From a medical clinic, things that we're working on in Riverside, navigation centers, navigation centers, mental health beds, bridge housing centers, emergency shelters, a new medical clinic that we're working on. All those things have to be offered in a way that is consistent and ultimately leading to a housing unit that is safe. Okay, I'm done. Just a quick plug here for the homeless lab. There's my name and number right there, so if you have any questions.
So the question was, how do we prevent the liability, or how do we take on the liability when we put somebody into some kind of housing? It's something that we worked out with the Loma Linda Inn, as well as we just started with another place, in that they would accept that risk. That we try to ensure that when we send somebody there, it is with the safest possible outcome. We have somebody who has been an IV drug abuser. We don't send them with a PICC line. Somebody we would probably keep in a hospital and treat here. So we try to ensure that the services they're going to receive can be done in a safe manner. It's not easy. Sometimes things happen. So.
I think I see a hand right back here. Yes.
In studying the problem, I'm wondering if some of our municipal policies of encouraging business while restricting or limiting housing with slow growth and no growth initiatives have sent demand and supply in opposite directions and made the problem much worse rather than better. And what can we do about that?
I don't know which of you might want to take that on. It looks like
Yes, it has made it worse. Simply those policies cause there to be a significant gap in the cost of housing and the ability to afford that housing. So yes, absolutely. Slow growth, no growth, the desire to remain small town or whatever the words are, it's not helping. And we do need to be able to just provide more supply. I mean, not simply affordable housing, but simply more supply. So that's definitely the case.
Is another possible solution to tell businesses no, you cannot move here or you cannot expand here because we have no housing for your employees?
I suppose so, but I don't think so. I for as long as the population continues to grow, okay, then we need to make accommodations for that growth in population, because otherwise the new population will be suffering. I do think that we need to acknowledge that population growth and something better, something bigger than that. The people are most happy when they're around other people. And so don't put something in some obscure place. Make sure that it is in the midst of the amenities that are there. So.
all right, Floyd, right down here.
The homeless problem has interested me for a long time, having lived in Loma Linda for over 35 years. And the first question comes to my mind, the way we live is a continuum. I'm sure that there are people living in Beverly Hills who, if they drove by my house in northern Loma Linda, would click their tongues and say, how does that guy ever survive in that poor place? And then I look at somebody down the street in their car and I say the same thing. So where do we draw the line? The other question is this. There used to be a fellow who used to sit on the bench out here, kind of a scruffy looking guy, in my opinion. And he lived in the storm drain up by the Ronald McDonald House. Every time I talked to him, I could get 2 words out of him only. Killing time. That's all I ever got out of him. They found him dead in the storm drain in a shopping bag by his side. He had $13,000 in cash and a deed to a house in Northern California. There was another lady living here in Loma Linda for a long time. I haven't seen her now for a couple of months. She used to live by City Hall and then later on down by the post office. And on a number of occasions, my wife has gone to her and asked if she could help, and she will bluntly tell you, I do not need help. Is it right, is it possible that people can choose in whatever capacity they're in to live the way they want? How can we address that issue?
Sounds like one for you.
So the projects that I work on, like the Hollywood project, the 14 individuals or the individuals that I work with, they've resisted services for decades. Resisted service for decades. So what I do is I go out all the time. I don't take no for an answer. You're not going to tell me, no, I don't want services, and think I'm going to walk away, and that's it. We're going to keep trying and trying and trying and trying and trying until we're able to get you into services. And that's just the model that I work from. We're not just going to, you go to the hospital, we're coming in the hospital. You have been inpatient, we're coming in inpatient. We're talking to the doctors, we're talking to everybody, because we're not just taking no for an answer. Because people that are severely mentally ill are very resistant to services. And services has to get past that place where people just say no and we just walk away. And they die on the streets. It can't be that way anymore. Self-determination, I understand and I get it. But where does self-determination stop? Where does that stop at? If somebody's sitting in the rain for 15 years and it's pouring down raining, and they're sitting there in the basket and they say, I don't want services. Is that a mental illness if their leg is wide open and they got feces all over them and they say, I just don't want services, and we just walk away? Is that humane? So I just don't stop.
Probably time for one more, Jason.
I think I can speak without the mic. So there's a lot of reasons for homelessness, like you pointed out. I was surprised how many homeless people here in San Bernardino were working and still couldn't afford rent. So the housing issue is critical. But even moving further upstream, how does workforce development tie into making sure people can afford housing? And how are we connecting those dots?
So that's a really good observation. Yes, a significant number of the people that are homeless, including unsheltered, are working and working full time. And something close to around 48% of the people that are in the city's homeless shelter are working full time. Okay. And I think you're right. I think that we have to, not that I know how, okay, but I think that you're right, that we have to make an effort to not just bring down the cost of housing, but also develop wages or develop better jobs. I don't know exactly how we would undertake this, but I can tell you right now that a person that is working full-time at McDonald's, because that's the job that they have, they're likely to still be homeless in some way. So we have to be able to kind of attack the ability to live comfortably in a unit that they can afford from both the cost of housing angle and both the wages angle at the same time. Maybe education, I don't know, maybe community.
You know, in LA County, they talk about the 55,000 homeless individuals in LA County. My friend Steve Lopez, he's done an article not too long ago. I don't know if you guys read that article, where they went into the school districts and they came up with a staggering number of 300,000 kids that are homeless in our system. So when you look at homelessness, you see how it affects children. We have families living in motel rooms that are working, but they're bouncing from place to place to place, and they're homeless, and their kids are homeless in our systems. So when the LA school strike happened, these kids were without food. They just went without food.
Just an aside, in Riverside, the count is 500, in Riverside, the count is 551 kids that are actively going to school and still living on the streets. And can you imagine this respect that you have for this child that gets up and goes to school in the morning?
I see hands all over the place. I also see that really our time is up. Before we thank our speakers, let me just say that we invite you to come over to across the street to the Institute for Health Policy and Leadership anytime. We do a lot of policy briefs and issue briefs. One of them is on homelessness. It's a very helpful document, I think. And also go to our website if you would like, ihpl.lu.edu, where you'll find a lot more resources. If you have suggestions for future Spotlight on Health Policy presentations, let us know. We'd like to hear about that. And now I have a profound sense of gratitude to all three of our speakers for coming and helping us today.